Welcome, everyone. Thank you for the opportunity to come speak with my Brazilian colleagues. It's a pleasure to be here today. I only wish I was in Brazil. My wife and I last visited during our honeymoon, where we got to see lots of the beautiful country. We were up in Búzios and in Rio and Salvador, and so. If this is the closest I can get to Brazil, then I'll take it. But I'm really delighted to be able to share some time with you and talk about some of the work that we've been doing here in the U.S. I'm going to be talking about two sides of the same coin. I'm going to be talking about the challenges when patients demand medically inappropriate care or medically unindicated care, and the other side when patients decline or refuse what physicians believe is medically necessary care. And there's actually similarities between managing those two concerns. So they're two separate problems, but the strategies to manage them are similar. I'm not seeing the PowerPoint anymore. I hope it's still up there. Let me just make sure. Okay, good. It's back. Let me just say quickly about myself. I'm a hospitalist physician, and I work in the Department of Veterans Affairs, which is the largest integrated health system in the United States. We care for U.S. military veterans, and there's a series of 140 hospitals across the United States where we provide those cares in the inpatient setting, as well as 1,000 outpatient clinics. I work in the National Center there. It's called the VA National Center for Ethics in Healthcare, and we help to establish and promote standards for ethical healthcare practice. So we're busy writing policy and doing ethics consultation to try and improve ethics quality across our healthcare system. Okay. I have no disclosures to report, and the views that I'll be discussing today are mine alone and not the official position or policy of the agency I work in or the United States government. The learning objectives, we're going to be talking about a number of different things. We're going to be talking about the tension when we try and share decisions with patients, but also ensure that we provide care consistent with accepted standards of medicine. We'll talk about managing those encounters with skills that both help patients and actually help hospitalists. We're going to talk about both sides of those coins, as I said, both responding to patients' requests for non-indicated care as well as working to help patients avoid harm when they refuse recommended care. I want to say very, very little about this, but I wanted to bring it up because in the field of ethics, we talk a lot about values-based versus rules-based considerations. And also, practically, one of the most common questions I'm confronted with when there's an ethical dilemma is, well, what does the law say I should do? And the problem with that is from an organizational perspective, we need more than just the law. We also need ethics. Ethics can inspire us to do so much more. And I use this graph to show us a little bit about the differences. So rules define prohibited minimal behavior or prohibited behavior or minimal standards, but they don't necessarily inspire us or provide exemplary practices, right? So when we talk about hospitalists or physicians concentrating on what they must do, that's a rules-driven organization. But in a values-based organization with a strong ethics environment and culture, we talk about what hospitalists should do. right? And that means finding ethically optimal ways to act on the rules in service of the organization's mission. And so that means thinking about ethics every day. It means working within the rules, but going beyond that, going beyond the minimal standards so that we're talking about openly and ensuring that ethics is part of everyday decision making. So let's move to a case. This is a fictional case. This is a 95-year-old man with end-stage dementia, metastatic lung cancer with metastases to the pleura, brain, and spine. He's on third-line chemotherapy, and he was admitted to the hospital with hypoxic respiratory failure and acute on chronic kidney injury due to septic shock. So he's been in the hospital for 2 weeks. He's on antibiotics, he's on vasopressors, and the patient's getting worse. He's actively dying. He has kidney failure, and his blood pressure is dropping despite being on vasopressors. The patient's family wishes to extend life as long as possible and asks you, as the hospitalist, can we initiate hemodialysis? So we'll come back to this case, but let me talk about some of the principles involved in thinking about how to address these concerns. Because I think once we have some of the principles, the case is less relevant because we can apply those principles in lots of different circumstances. Okay.
You lost your slides again.
Yeah, let me reshare them. Okay, good. Okay. I want to talk a little bit about patient-centeredness. I don't know if you have this experience in your country, but I feel like I hear patient-centered care everywhere all the time. And it can be a problematic phrase because sometimes people put patient-centered on the end of an argument to try and justify their argument. They say, well, if you do that, that wouldn't be patient-centered. And that kind of stops the conversation because you can't really disagree about whether or not you're patient-centered or not. Everybody wants to be patient-centered. So I want to clarify what it is because it's so critical to high-quality patient care. And patient-centered was really defined about 20 years ago in the United States Institute of Medicine report called Crossing the Quality Chasm. And that set out 6 aims for improvement for the healthcare system to address. And one of those was patient-centeredness. The others were safety, effectiveness, timeliness, efficiency, and equitable care. So all those elements are important, right? But of all the things to pick in medicine, this body from the National Academy of Sciences, made up of esteemed scholars, policymakers, and leaders, they chose patient-centeredness. And I think there's huge implications for our health system and how we treat patients. So here's a definition, and it's from the IOM report. And patient-centered care is providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. So in other words, simply stated, it supports patients to make input into decisions about their own care. And how do we implement patient-centered care? Well, we enact it through shared decision-making, right? And shared decision-making has been defined lots of different ways, but in general, I like this definition. It's a process by which patients are educated about the likely treatment outcomes with supporting evidence and engaging with them in deciding which choice is best for them, taking into account their preferences, values, and lifestyles. Now, I imagine you're having some of the same debates in your country as we do in this country when we talk about high-value care and low-value care. We talk about lots of treatments that we want to share with patients, right? So mammography, antihypertensive therapy, screening for prostate cancer with PSA screening, end-of-life care, colonoscopy screening. Those are all guided by the model of shared decision-making, right? And again, that's where the physician and the patient come together and agree about a formulation for how they're going to decide about this particular treatment or procedure, right? And that means identifying that there's a choice involved, that there are risks and benefits for each of the explicit options available, and then helping the patient decide from among those choices based in part on their values and preferences for care, right? So the physician brings the medical knowledge and expertise about the evidence-based options, and the patient brings their own values and preferences about what's important to them. And why I think this is interesting is most decisions in medicine would benefit from shared decision making. And when every time we try and identify one that isn't, we have a little bit more data that tells us why it's more relevant. So the example I give is an appendectomy for acute appendicitis. Well, when I was in medical school, it was you had surgery or you didn't have surgery, and not having surgery was not a good idea. But now we know with emerging research that actually there is a role in certain patients for IV antibiotic therapy to avoid surgery and the potential complications. And that's a potential medically acceptable option that are available to patients. Now, we can apply that to lots of different decisions in medicine. It really comes into goals of care when patients are talking about maximizing quality of life over longevity at the end of life. Their values are relevant to what's best for the patient. Now, what's not shared decision making? Well, a patient doesn't get to decide what size endotracheal tube to use when they're getting intubated for a procedure, right? That's not that is value neutral. That's entirely determined by medical standards, right? However, what about an opera singer, right? An opera singer may not want an endotracheal tube for their procedure because they're very concerned about their vocal cords. And so involving this opera singer in the decision about how they're going to be intubated for a procedure might mean seeing that an LMA airway or some other airway might be best for that individual because they want to protect their airway, and endotracheal tubes are at higher risk. Let me make sure I'm sharing again. Okay, good. Okay. So this creates this tension, right? We want to give patients what they want. We want to share decisions with them. We want to provide patient-centered care. But we also want to make sure that we're providing care consistent with medical standards, right? And that can be a real tension from the medical provider's perspective. And I want to explore that a little bit more. So what does it mean to give patients what they want, right? Well, that's an important part. I mean, as patients ourselves, we can imagine that that helps promote our involvement in care. It ensures that patients get to take actions on their life based on values that are important to them, and those may differ from the recommendation of the healthcare professional. And again, it tends to place the interests of the patient above everybody else. There's also lots of new research suggesting that patient-centered care and shared decision-making promotes better patient satisfaction, better treatment adherence. It can reduce health disparities. It potentially can reduce cost. And so there's a real role for it. But what about the other half of the equation, right? And that's medical standards. And why are medical standards important? Well, I would argue they're at the core of the medical profession. They help to define the profession. They help to establish professional integrity. And I want to talk about this a little bit because I think it's interesting for physicians in two different countries to be able to share values about what makes a profession. So I want to talk a little bit about that. I mean, what is a profession? How are me and you, thousands of miles away, what do we share in common in the work that we do every way, right? Well, a profession like a medical profession is a specialized, complex body, has a specialized, complex body of knowledge that's used in the service of others, right? We're committed to competence and integrity and altruism, and we're accountable for the promotion of the public good. And finally, we act according to transparent sets of standards, right? We have codes of ethics, we have clinical practice guidelines, we have evidence-based therapies. Those are all transparent sets of standards. And the sociologists who study this, they talk about a social contract, right? And there's a social contract between the profession and society. And the society permits the profession to have a monopoly on its service, right? Only physicians can provide certain procedures. Only surgeons can do surgery, right? Only physicians are allowed to intervene in patients' lives in that particular way, right? They have a privilege to do that, and they're often self-regulating. But in exchange for that, right, we have to be accountable for the promotion of the public good, right? So medical standards are how we legitimate the practice of medicine to society. So how does this relate to this discussion we're having here? So there's an ethical and a legal basis for physicians' authority to limit access to certain medical treatments or procedures, right? So the healthcare professional possesses this authority based on their expertise, their knowledge, their medical training, right? I'm talking about what we share in common here, right? And in my country, this authority legally is granted by, we have a state licensing board. So I'm licensed in New York State to practice medicine, and I can't practice medicine without that state licensure. I'm also certified by a medical specialty board, by the American Board of Internal Medicine, and I'm credentialed and privileged by the healthcare institution where I work. So that provides me with a lot of authority, and I have a lot of expertise because the state required me to go to college and 4 years of medical school and multiple years of residency training, right? But what about from an ethical perspective, right? I mean, from an ethical perspective, being a member of a profession grants us an authority that requires responsibility. Providing medical treatments must be in accord with accepted standards of medical practice because that protects patients from harm, right? There's an expression in our country that we're not snake oil salesmen. Years ago, and hundreds of years ago, there used to be what they were called snake oil salesmen that went around to villages and sold people snake oil and said, it'll cure you of this or it'll cure you of that. They weren't physicians, right? And so physicians have their integrity to protect. They have the integrity of the profession to protect. And we do that, again, through medical standards. So to provide treatments that are not in accord with accepted standards of practice would threaten the legitimacy and the integrity of the profession. And more importantly, it would limit patients' trust, the public's trust in the profession. And then finally, transparency, right? In managing these conflicts with patients and their families, we have to be able to demonstrate what these standards are. Right? So in other words, the standard has to be transparent. It has to be accessible to others. So it's not just in my head, oh yeah, that's just something that I do, right? Or it's not in my experience, but there's something in medical literature, there's something in a clinical practice guideline, or some other referable authoritative standard. And why is transparency important? Because it promotes fairness, right? So that the standard is applied to all similarly situated patients. If you can tell a patient, here's the standard, and that's why I can't provide you this treatment, then they know it's not because of who they are or how they look or how much money they have, but because you're appealing to medical standards. And one way to think about this, and that I ask clinicians who I work with, are I say, who gets to decide, right? Do you get to decide this decision, or does the patient? And the reason this is an important question is once you know the answer to this, a lot of the tension goes away in conflicts, right? If you can say, oh, the patient gets to decide this, your shoulders relax. You realize you can advise the patient, but at the end of the day, they get to decide from within that range of options. So I like to sort of provide a couple of examples, right? So in these cases, who gets to decide, the patient or the physician? Well, what if a pulmonologist is consulted? Well, in the United States, in the inpatient setting, it's generally the physician gets to decide. A patient can't pick up a phone and call up a pulmonologist and have them come see them while they're in the hospital. The attending physician in the hospital is in charge, and they decide who is involved in the patient's care. In the outpatient setting, it might be different. A patient could just go straight to a pulmonologist. If life-sustaining treatment is withheld, who gets to decide? Well, the patient gets to decide that, right? Patients get to decide whether or not they accept or decline treatments, and that includes life-sustaining treatments as well. What about if a treatment is medically indicated? Well, patients don't get to decide that, right? Physicians get to decide that. They can't say, well, I want you to give me this antihypertensive therapy to cure my cancer. Well, we would say that's not medically indicated for that condition, and I'm not obligated to provide that therapy, right? So that decision resides with the physicians for all the reasons that I described on the previous slide, based on your expertise, your knowledge, your training, and the authoritative standards that you've used to make that decision. We'll talk a little bit about how patients can leave AMA, but generally competent patients have the authority to decline recommended treatments and leave the hospital. The next one is interesting. We don't have enough time to talk about that, but it's a big issue here in this country. Can patients record clinical encounters? And everybody's got a cell phone now, and it makes physicians very anxious about whether or not patients are recording their encounters. Are they broadcasting it live on Facebook? Are they putting up a YouTube video? And it depends in this country, in part legally, about who has the authority to decide to record clinical encounters. Sometimes it's the patient, and sometimes it's the physician. But the important part of this exercise is to remind you who gets to decide, because that helps to really sort of hone in on what the problem might be. So let's switch gears to a case example. We're going to talk about an AMA discharge. So this is the other half of these dilemmas. We have a 48-year-old man with high blood pressure, diabetes, and alcohol use disorder. He's admitted for management of acute kidney injury after he stopped taking his medications and started drinking some more. A day later, his acute kidney injury is not resolved. He angrily reports to the nurse that he wants to leave. The physician is asked to sign an AMA discharge form, and the patient is discharged without prescriptions or follow-up appointments, and he's told to return to the ER if he develops new symptoms. So we don't have a polling function here, but I want to ask you, in your head, think about this. When I think about taking care of these problems, what am I aware of feeling? Am I interested and engaged? Do I feel like I failed the patient? Am I frustrated? Am I neutral? Do I feel unappreciated? And you may have, maybe your feeling that you're having is not listed here. Maybe you have more than one. The reason I bring it up is this is an exercise in recognition of our internal states and how they may contribute to our capacity for problem solving, right? So if you're feeling angry and frustrated, it's often harder to brainstorm about how you can help the patient. So I'm not saying it's abnormal to feel that way sometimes, but the more you are aware of how you're feeling, the more you can use that as a clinical tool in thinking about how you can help the patient. Again, this changes over time. When I was an intern, my patients wanted to leave AMA, I was B and E. But now with practice, I mostly am A. I'm mostly interested and engaged. And there's a book called The Art of Possibility that I really like that advises the reader in situations like this to train yourself to respond to these challenges with the phrase, that's so interesting, right? And the idea is that stimulates curiosity rather than a more negative or unproductive emotion. Let's talk about the difficult patient, because I'd like to talk about language and how that influences how we think about taking care of patients. The patient I just described sounds like many healthcare professionals would call difficult, right? He wastes our time, he doesn't follow our advice, he keeps coming back, he doesn't get better. But I'd like to suggest that there's something wrong with the label of difficult patient. And partly it's because there are values embedded in the description. and they're pejorative, right? They're negative value judgments. And it's also problematic because it's not objective, right? It's a subjective assessment. One physician will find this patient difficult, and another physician will say, it reminds me of my brother-in-law. I can handle it. And also from a research perspective, how do you measure and study difficult patients if the term isn't reproducible and not standardized? So how do we study these patients? How do we think about these patients? Well, we have to reflect the inherent relationship that occurs with patients and providers. And we have to suggest that there may be a healthcare professional's potential contribution to this clinical problem, right? So when we talk about difficult patients, I suggest that we rather describe them as difficult to help, or a difficult doctor-patient relationship, or a complex clinical encounter. And that moves the locus of responsibility away from the patient and to the healthcare professional. So I want to explore that a little bit more by thinking about this. AMA discharges are defined as when a patient leaves the hospital prior to a clinically specified and physician-recommended endpoint. I don't know, I'd be curious to hear if there's the languages in Portuguese, but that's how we describe it in English. It's an against medical advice discharge. And there are adverse health and health services outcomes with these patients. These patients have, excuse me, higher rates of 30 and 60-day mortality. They have higher rates of 30-day readmission to the hospital. They don't use outpatient care as much. And this falls upon primarily disadvantaged patient populations, patients with lower socioeconomic status, substance use disorders, HIV, psychiatric illness. And mostly, excuse me, mostly we know about this from studying patient-related factors of AMA discharges. So, excuse me. As long as there have been doctors, there have been patients who have ignored their advice. But the more we learn about AMA discharges and how physicians and patients negotiate treatment, the more we realize that AMA discharges may not be the solution. We know from the literature that patients who are discharged against medical advice report an unwillingness to return for care. They report feeling stigmatized. And so far, no study has ever identified a benefit of designating a discharge as AMA. So I like to think of AMA discharges as low-value care. You may call it something else, but essentially there's identifiable harms. There's really no identifiable benefits. And so it's a practice that I would say from an ethics perspective, we should stop doing. Okay. I think we're running short on time, so I'm not gonna talk about this slide very much. This is the, I don't know if you learned about this in medical school, but this is the patient with the abdominal gunshot wound that resulted in a gastrocutaneous fistula. And there was a physiologist who worked with this patient by inserting pieces of food into the fistula, and he advanced the understanding of gastrointestinal physiology that really advanced the field. And these are called strategic research materials. And what I like to say is it's possible that AMA discharges are strategic research materials. And the reason they might be is because we can learn a lot from AMA discharges. They're low prevalence. They're about 2% of discharges within the US, but that's about 500,000 discharges in this country. And if we understand AMA discharges, we may understand the larger problem when there's disagreement between patients and physicians. So the more we know about AMA discharges, the more I think we can understand and respond to conflicts in general between patients. So when there's not adherence, when patients disengage with care, AMA is an extreme representation of the more general challenge when patients disengage with their care providers. And so I find it's a helpful model for help us thinking about general conflicts in patient care. So we come back again to the decider, right? And these are the primary management principles for AMA discharges, right? So patients with decision-making capacity, competent patients, have the right to decline recommended care, right? Physicians are not wardens, they're not jailers, they're physicians. And patients are free to make their own choices. Now, the worst possible interpretation of this is to say, well, the patient's on their own. They can do whatever they want. That's not what patients need either. Patients still need physicians to help them make those decisions. They need support. They need guidance. And again, that's where the shared decision making comes in, right? And we talked about that. And I would say that decisions about hospital discharge are the same about any other decision that you're helping patients make. We need to elicit patients' values. We need to find out what's important to them. And we need to help them make decisions that are right for them. Now, part of the hard part about that is sometimes accepting patients' values, right? Patients may not always prioritize their health, or it may be a priority, but it may not be their number one priority, right? If it were, no one would smoke, right? So patients are often making trade-offs in what's important to them, and our job is to help them with that, but not to discount everything else that they consider important. So how do we do this? And part of the way to confront this issue is through harm reduction. And you're probably familiar with that concept. It was actually originally developed by a Nobel Prize winning economist in the 60s, Herbert Simon, where he said that he described it as satisficing, and it allows one to consider decisions, while not perfect, satisfy to some extent, and allow you to make a decision given those values conflicts. So it's a good enough decision given the circumstances. And I like to show this graph to help us think about this problem. So what do we do with patients who are deciding to decline recommended advice? Well, they're everybody that's above the bar, right? So of the bar is medical standards. That black bar is the medical standards that we talked about. Everything below that bar are options that a physician is neither obligated to provide or offer to the patient. Okay, so that's the patient who says, I know I'm having an acute myocardial infarction, but I want to go home, right? That's not an acceptable, you wouldn't be able to devise a discharge plan that would be safe under those circumstances. So that's an option that's not in accord with generally accepted standards of medical practice. But there's a lot of decisions that are above the bar, right? And there's decision A up at the top. That's the right answer that you took on the test when you were in medical school. But there's a lot of other options in there that may not maximally promote the patient's health, but they may still be in accord with accepted standards of practice, and they may be acceptable, right? So option B might be the patient that wants a once-a-day antibiotic, even though it's not as effective, rather than taking a 3 times a day antibiotic. Or option E might be the patient that says, I want to leave a day early from the hospital because I have something important to do at work, even though that increases their risk for readmission. So those are ways to think about how do we help patients in making decisions that may be above the bar. They may be acceptable, but they may not maximally promote their health. And I know we do this all the time with our patients who are not willing to accept necessarily the best medical treatment. Let me close with some behavioral strategies for AMA discharges, and this is in Holly Fleming's chapter in a book we published last year. What are the things you need to do when patients decline recommended treatment in the hospital? Well, first you need to involve other people for support, right? You need to get the patient's primary care provider involved. You need to get their family involved. Other people may be helpful in convincing the patient to stay. 2, you need to maximize patient control, right? The more the patient feels that they're in control, the better you're going to have a chance working with them. Patients often feel out of control in the hospital. 3, you have to empathize and not argue. Arguing rarely works with patients, and empathizing with their position, with being in the hospital, will often begin to improve the relationship so that they can begin to trust you. You need to rely on your trusted legal advice. Within my hospital system, an AMA discharge is not legally required. What is required is that you have an informed consent discussion with the patient and you document that in the record. You would check with your own regional counsel or your legal counsel to find out what's legally required at your facility. I encourage you to see conflict as opportunity, not just as an unpleasant interaction with the patient. We need support from addiction specialists. Many of these patients who leave AMA have addiction use disorders, and the more help we have from specialists, the more we can reduce AMA discharges. And then finally, we want to make a conscious choice about AMA discharges. Again, in my hospital system, you're not required to do it, and I would suggest that it's low value care, so it's something that you may want to consider not doing. We're short on time, so I want to skip over some of the research we've been doing on identifying other factors that affect patients' willingness to leave AMA. Leave it to say that there's more than just patient factors. There's also provider, hospital, and health system factors. So with that, let me summarize and close. In summary, it's if you're going to deny patients access to medical treatment, it's only ethically justifiable when it's based on transparent, widely accepted medical standards. The skills for managing AMA discharges can be applied across the spectrum of care. We didn't get to talk about how designing interventions for AMA discharges, it needs not just consideration of what the patient is doing, but also hospital factors and health system factors. And then finally, the importance of keeping patients engaged in their care by practicing shared decision-making and harm reduction.